Today we've had quite a few people send in questions regarding patients. So we'll start by going through them because there's about a dozen different cases, and they're quite good ones to go through and talk about. So we'll run through the questions as they were posted over the last week, and we'll run through the cases, the ones that have been sent in as well. So Cindy sent in a case on Monday. Cindy, are you there?
Yeah, I'm here.
Cool. So I'll read through so that everyone can get a heads up on what it is that you're asking about. So I hope all is well. It's been a bit hectic. They've just opened up your schedule. So obviously wanted help on a case. And the background, the patient is 10 years old. He's seen a couple of orthodontists that have recommended extracting impacted canines on the upper left. He does need further maxillary expanding and uprighting of mandibular teeth. The pan on the file is a bit outdated. All his permanent teeth have erupted, including his second molar on the left. I know your lecture, you mentioned addressing the AP first, and that's specific to the upper left quadrant, before the transverse. Have you done similar cases to this one where you've distalized the entire upper left quadrant using the Wong appliance before expanding transversely? All right, so let's have a look at the case itself. Okay, so we'll just go through all the images first and then we'll talk about them. So we have lateral profile, we have a front facing view, and we have a front facing view with a smile. We have a lateral ceph, we have a pan x-ray OPG, we have 3 photographs intraorally. So do you want to talk about this, Cindy, and then I'll give you my thoughts?
Yeah, sorry, what do you mean, Simon?
So
Just kind of my,
what, because you've been given the advice to take out this
yeah,
canine,
okay,
yeah?
right. So this pan was taken, I want to say maybe 6 months ago.
Mm-hmm.
But now, his primaries have all exfoliated. And when I'm looking down, yeah, on that occlusal photo, the left side, the canine is completely blocked out. And I know I'm not surprised that really, the treatment of one of the options is to extract the premolars, and then, you decide how many premolars to extract on the other side for symmetry and all that stuff. But and I feel like what makes it a little more difficult is that his upper left, the second molar has erupted too. So it's much more difficult to distalize uh, upper left 6 if I were to consider doing that. And
And then, this was something that you have done, the Hyrax thing,
so he,
banded.
so he came with that. Yeah,
Okay.
that's what. So that's what
Because
they.
there's no, those X-rays don't show the appliance in them.
Yeah,
So,
that's right.
but these were X-rays that were done somewhere else.
No, so we did it in my office, and then he went to see an orthodontist.
Yeah.
We started the expansion, and then mom wasn't comfortable with extracting premolars or premolar, and so she wanted my take on it.
Mhm.
But I feel that he's just so retrusive, right, by Max, both and his profile, his soft tissue, and everything. So and he's not a small, he's not a he's a bit husky too. So just kind of thinking from an airway perspective, I don't think
Mhm.
extraction, if there is an alternative option, I think
Yeah.
non-extraction would serve him better, just with everything working against him.
Okay. So, um, uh, so one of the things that I'll go through is I'm going to talk briefly about records, and then I'm going to talk about my thoughts on the case.
Mm.
So the records here are insufficient. Um,
Mhm.
it's just not enough information to do a formal evaluation. But of course, you know, I've done this long enough to be able to make a educated guess based on the information that's there. But it is important that this format of how the X-ray is set up on a PowerPoint is neither here nor there. So, guys, one of the things that we do is we either make a decision, we either display it in the ABO format, the nine squares where you put the images of the extraoral and intraoral all on the one panel, and then you have the two X-rays separately. Or you can follow my method, but if you chop and change a little bit here, a little bit there, then it's neither here nor there. So that is just a, a bit of advice for everyone. Now, as far as the important component, which is the head and the face. If we look at the image, we would say that this boy has a nose, an upper jaw, and a lower jaw, all in separate time zones. Yeah, um, they don't belong to each other at all. They're not even distant cousins. So we know that this is not a good face. Now, from the front, it's not that obvious, and a lot of the issues are hidden by the fact that this guy's got a nice square face. So he won't care, and his parents will probably not want to think about it too much, so they won't see it. The issue that we have, of course, is he's got everything working against him. He's got baby cheeks, but he's got so much power that you don't see his lips. All right, so he's so tight he can't smile without showing his teeth. So we know these children squeeze their extra oral muscles so tightly that the bones have got nowhere to go but back. We know that we can always squeeze a mentalis much heavier than anything else in the front section, so we end up with that scenario. So there was no analysis of the X-ray, but we know that this is a significant class 2, tending division 2. We don't have a...
Yeah, I think I forgot to send in the photos, the other photos with it.
Yeah, yeah.
Yeah.
So at the moment, we know he's locked back a long way. Um, we also know that that is the classic scenario where the canines are always blocked out because everything's shoved back. So we know that both the upper and the lower jaws are too far back, with the lower jaw a lot further back. We also know that he's got a soft palate that is very, very close to the back of the nasopharynx. And if we have any retraction here further, which is going to happen because he's got a tight upper lip, then you add that on with the fact that he's a chubby boy, and he probably likes his sweets. Before you know it, he's not going to have a good breathing experience at night. Whether that happens or not now is irrelevant because it's going to happen sometime in the future for him unless something changes. Now, we can't control his weight, but we can look to see what things can be done to help improve his jaw development. So his jaw development is one where he's got close to 80 odd percent deep bite. So that tells us he's always got his teeth apart, always. But he's always got his lips together. So that allows for supereruption of the upper, and it creates some dramas with when you combine that with tight lips, everything getting squeezed back. So the simple solution to this is that this is a skeletal issue, and there's not a lot that you guys have the capacity to be able to do anything other than hide that. So the question the mum has to answer is, once we highlight that this is a significant skeletal issue, is she okay with that? Does she want something done about it? Now, I have the capacity to correct that, but most people don't, other than using surgery or using camouflage. So one of the questions that we have to ask is, can we get his teeth in line so that it doesn't look so bad without messing up his airway or making his face look a lot worse? And then what we've got to do is determine, well, what are we going to do in this scenario? The first question is this midline on the upper? Is this everything swung to one side, or is this the whole distal section mesializing? And you look at there's not enough information here to make that determination because I can't see his teeth when he smiles. If you look at his pan, then maybe his midlines are on, and if you look at his palatal suture, then maybe his midline's on. So there's a good chance that this is all this section mesializing. Now, how are we going to get this back without completely messing everything up? Well, the answer is you're not really. Now, you can open up this space, but it kind of messes everything else up everywhere else, but it's possible to do. Then you've got to work out, well, if we mess all the teeth up to open that space, and it is possible, so you can put a sagittal screw here and you can open all that up. So it's definitely possible. The question is, this will all get thrown out to one side, and that will get thrown out to one side, and you'll need significant time in fixed appliance braces or Invisalign to tidy it all up. And then where will you end up? Well, you'll end up really displaying the significance of the of the A and B discrepancy, right? You'll make a huge overjet because they'll come forward. As you try to open up that space, those teeth are going to come forward a long way. Now, if he was heavily division 2 retroclined, then I wouldn't hesitate. But his incisal relationship is only is upright, right? It's not retroclined. So he'll end up being more protrusive, which is never a bad thing in a face that's set back. But what's going to happen with his lower arch? Well, the answer is probably nothing. It's not going to change much at all. So what we're going to end up with is you'll get the upper arch to fit, as we all can. We can all, everyone, there's no person on earth who does ortho who can't get all the teeth into the upper arch. The question is, what happens in the lower arch? And will they marry up later on? And there's a good chance that that won't happen. If he was division 2 heavily, his lower jaw would track forward. Like it will track forward. But he's not. So there's a good chance it won't, especially with the lip and mentalis of that level of activity. So he's going to stay really, really, really retrusive. And is that okay? All right, is that part of the plan? It's not a problem if you unravel everything, level and align it, get all the teeth together with the goal when he turns 18, you're going to do surgery to correct it all. But if you're not, then you've got to think, well, what's acceptable, what's not? What's the least amount of time you can put him into whatever you're doing, fixed braces, to get him lined up as quickly as possible without messing everything up. So the longer you're in braces, the longer you're in treatment, the more vertical and the more retrusive you're going to end up. So the simple answer is, if you're playing the game of ortho, the simple answer is take out that premolar, get his canine in, and call it a day. All right? Put the braces on, put the Invisalign on, whatever. If you rip that tooth out and let that canine in, how long would it take for you to get those teeth straight? Cindy?
If you just extract that premolar?
Yep, just that one.
Yeah, it wouldn't. I mean, the canine
Wouldn't
would
take long. So that would be the game plan, right? Unless you're prepared to do surgery.
right.
I would say, I would look him in the eye and say, I would do surgery. If you're my boy, I would do surgery. Are you okay with that? If they say, oh, no, I couldn't do that, then I say, well, find an orthodontist who's happy to pull that tooth out, because it won't take long to get them straight once that tooth is gone.
Okay.
Yeah. So I would that's how I would present it. Now, I would present it also slightly differently because I can do orthotropics, right? I can do the big But I would still do the same presentation. I would say, this is what I could do, but it's a huge energy and effort. And it's actually really, really difficult in children who have these immense, powerful muscles at the facial muscles. Yeah.
Yeah.
So I would present this as a surgical case. I said I wouldn't do it. It's obviously a surgery now. It's something that's a decade down the track. But you could do it one of two ways. You could try and get the canine in so that you could maximize everything for the future. Or you just pull that tooth out, let it all drop in, and then get everything else straightened up and see where it goes from there. People say, well, what about the asymmetry and the this and that? And sure, these teeth will never fit as well as those teeth together as this side does. But, these are just, as John and Mike Mew say, these are just ivory posts. Who cares?
Right.
What are we going to do to make the face better or at least not make it any worse?
Right.
If you take 2 premolars out because you want that symmetry, I mean, the thing is that, how is that more symmetrical? If you think about it, right? We've all done 2 bi-extraction cases, yes? How is that more symmetrical than just taking 1 canine out, than taking 1 premolar out? Because if you take 2 bites out in a heavy division 1 case, right? You still got less teeth on the top than the bottom, yeah?
Right.
And you're happy with that. So what does it matter if you've taken 1 premolar out on one side only?
Right. Yeah.
You're still going to end up with exactly the same result as if you'd taken 2 premolars out on the upper.
Yep.
So that's how I would approach it with the reality of where we are with the capacity of where you are now.
Okay. I mean, let's say even with orthotropics, though, do you think at his age?
This is an extremely difficult case for many reasons.
Right.
As a general rule, overweight children don't have the discipline to do orthotropics. All right, because they don't have the discipline to control a whole lot of stuff in their life.
Okay.
And yeah.
Yeah.
Okay. Cool. All right. So that's that case, and then Melanie, are you there, Mel?
Hi. Yes, I am.
Hello. How are you? Okay. So you sent the case in this week as well, and let's go through. Let's actually go through the photos first, and then we'll go through the questions, okay?
Yep.
Okay, so 8-year-old. So we presented with a bite. We'll go through the photos, then you can talk us through it, and then we'll come back to my thoughts, okay? So
Okay.
This is the retracted smile and the open retracted.
Yeah.
So we've got laterals erupting very palatally. We've got obviously some heavy wear. So from a CBCT, so all the teeth are there. So a girl with retruded lower. So one of the things that one things that I'm always looking for is, are we a smiley face, are we a neutral face, or are we a frowny face? And generally kids who never have their teeth together have frowny faces, because you're not closing your lips by activating the masseter temporalis. You're just squeezing the facial muscles together. All right, so that's not quite where it's supposed to be. So the self-evaluation, so if we look at the axis of growth, we are more horizontal. We have SNA of 77 and SNB of 75. So it's both jaws are retruded relative to what we would like, and A and B of 2.7. So it's a class 1 tending, it's a class 1, but both jaws are set back. And it's not a divergent growth. So that's the only thing that we're really interested in there. Okay, so we have a dental class 2, deep bite. Yeah. Okay, so what we can do is when we look at the condyles, we can see if they're centered or set back. And if they're centered, that means that the jaw will not come forward if you unravel the bite. But if they're set back, then the jaw can come forward if you unravel the bite. And that's more likely to be a division 2 situation. So the treatment plan is stage 1 upper, stage 1 lower. So we want to get more expansion and then train for posture. But you'd already started treatment, so you'd been at this for a few months and having some problems with the screw. So you built some appliances and you started some treatments with expansion. And it does look like there's a bite raising block or bite pads. So the bite's been opened up. And we have upper appliance with a bite pad, lower appliance. Okay, and this is the current. Is this the current? This is current. And when we bite in centric, we've got a lock bite at the front here. And I think the 6s touch, the palatal cusps are touching the central fossas. Low arch development. The canines are starting to flare out. There's still not enough room for the laterals. But the curve of Wilson is flattened out here, but we're tipping out the molars. Oh, something went wrong here. But we've got tongue trying to find its way out there. And that's her. Okay. So questions. 2 halves of the appliance feels loose on the screw. I've instructed the patient to stop turning for now as the screw turns so far that the appliance becomes 2 pieces. Intermolar width doesn't appear to have increased much, maybe to do with my own measuring, and didn't keep on top of it initially. Opened up her bite during the appliance wear, have the 6s tipped, have the lowers uprighted, have the Ds and Es intruded, have the 6s extruded. Combination of all scenarios. Do I need to consider intruding the 6s? The 6s tipping, can I stop it, prevent it further if I need to expand more? If I'm expanding more, should I only zero the screw or have a new appliance made? To bracket the anterior teeth, would you recommend going C to C? I realize another error I've been making is not seeing the patient enough. So every 4 weeks at the moment, and my suggestion is shorter intervals. Been ignoring the upper cat wires a bit in this case initially, as the laterals seemed so tucked in behind the centrals. Wasn't sure result of pushing the laterals against the centrals. I see now that the anterior space changing, that perhaps small buccal forces on the cat wire would work to get the anterior teeth more aligned. And then maybe I can use braces instead. All right. So her profile is nicer since she started. All right. So I can start answering some of the questions. Is there anything that you wanted to bring up in particular, Mel?
No, I'm just kind of wondering where to go from here.
So the first thing that we do when we look at these circumstances is this. So we have a deep bite, so that always, and we have heavy bruxing, so that always tells us that we've got our teeth apart all the time, our lips together, but we're a strong muscle tone. So bruxing, we've got to consider why we're bruxing. Most common reasons for bruxing is airway issue, chronic pain for children. So they're the two primary drivers of bruxing. So do we have any sleep history for her or any medical issues?
No medical issues, and I did not do a sleep history questionnaire.
So just something to consider when you see heavy bruxing. It's very common, those two reasons. So we then have a scenario where we've got a slightly deeper curve of Spey and Wilson, which is consistent with hanging the mouth open, right? So the tongue sits roughly there all the time, so it stops the teeth from erupting at the back, but tips them inwards. And then there's nothing opposing the upper teeth, so at the anterior teeth, so they just kind of erupt towards each other. But because your mouth is slightly open, you're more class 2, so you end up with that type of relationship. If you keep your lips together, then you're more likely upright or division 2. If you keep your lips apart, you're more likely division 1. So that slight retroclination tells us that she keeps her lips together a lot more, which means her nose works. So, one of the things that people forget is division 2s and thumb suckers, their nose always works. So it's not a nose problem for these children. Okay, so we're quite narrow, of course. When we have high extra oral tone, then everything collapses inwards. So you did some treatment and expanded her out. So because both jaws are retruded, so we definitely want to do something about it. We know that her bite is completely locked, so we know that there's no hope that it will fix itself, so we would want to do something about it. So the treatment that was carried out was by using appliances that expanded, but also that raised the bite. And, you can do that for a time because obviously you have a scenario where you've got teeth that are locked together. But if you keep, how long has this been going on for? How long has she worn these appliances?
They were inserted in September.
Okay. So, if it runs too long, what can happen in a heavy bruxer when you put pads over just 2 of the middle teeth? You can intrude them, right?
Mm-hmm.
And then when you have a rest wire that doesn't contact the molar, what can happen? You can extrude them.
Yeah.
Well, because they'll just erupt. You won't extrude them, they just erupt. So the pads will intrude or keep them from erupting, but because nothing touches that 6, even though you've got a wire there, but it's not engaged.
Mm-hmm.
So it might intrude. The width hasn't developed hugely, and sometimes is the appliance tight, Melanie? Is it fitting well, and is it snapping into place, or does each time they come in it isn't quite tight, and you have to rewind it back slightly to get it to fit properly?
It's lately it's been, well, she hasn't worn, she's been just wearing it. She hasn't been turning it for the last
Uh-huh.
time, for a few months.
Yeah, but initially, was it always tight when she came in, or was it always a little bit loose or not quite fitting, and you had to wind it back a little bit to get it in?
This one was okay. This one was pretty well fitting.
Okay. So one of the most common reasons for the tipping of the teeth is if they don't fit properly and they
Okay.
wind it. So what happens is they wind it and these ride off the cusps, they ride down. And then as you expand, it kind of tips everything out. So it becomes a dental alveolar expansion rather than a sutural expansion. So that's the most common reason for the teeth tipping out.
Okay.
The other thing is if they're unopposed completely, then they tend to erupt the way that they've been set. But if they're erupting and then they bounce off this and that, then they'll kind of bounce outwards. So they're erupting that way, maybe because they're hitting the ridge of the acrylic as they move out. So that if a tooth is erupting around your appliance, then your appliance can effectively guide that tooth into whatever position it forces it into. So sometimes that happens there too. But I almost never use bite pads. People say, "Oh, if they have a bite pad, how are you going to unlock a bite?" And the reality is, the kids that this bite relationship that they present with here, they're almost never in that position.
Okay.
Right? They've never got their mouth closed, these kids. Their lips might be together, but their mouth internally is never closed. So whether there's a bite pad or not is almost irrelevant because their teeth are never in contact. They're never like that.
Mm-hmm.
So that's just a thought anyway. What we're seeing is the expansion is pushing the primary canines out, which is consistent with what you've done with the wire. But do you want that much expansion of the canines? I would say no. So I would rebend these wires so that this tooth isn't continued to be pushed out. And I'd rebend that wire. And then that will allow them to fall back in a little bit.
Okay.
In the upper, there's nowhere for this to go with that wire in place, is there? So I would bend that wire so it sits more here, Oh, I'm not sure what I did there, but so that isn't prevented. Before, the teeth were locking everything together. Now your wire is locking that tooth from moving. Because normally what happens is if you're expanding and you adjust the cat wires, you can drive these teeth forward a little bit further at the same time. But you're blocked here, so my normal design here would have an approximating wire that sits on either side of this, and I would close the diastomer together. I wouldn't have the rest wire block this. I'd have the rest wire where I wanted it. And then at this point, sometimes I just I might cut it a little bit and just have it only a little bit engaged so that it doesn't stop that coming forward. And then I'd start to activate these forward. But that's, I've been doing this a long time, so I can do that. What you will probably want to do is you need to recognize that there's not enough expansion on the upper arch.
Yeah.
All right. So even if you got these together, it's not enough. So what you might do is you might build a new appliance, maybe without the bite block, everything fitting a bit tighter. And you might design it to allow you to put your brackets on. So you'd put brackets on the C and the 2 and the 1 and the 1 and the 2 and the C. But I wouldn't start that until you've got enough space. Okay. If you have not enough room, the teeth, when you put brackets on, just come forward. But if you have enough room, when you put brackets on, they just align. Now you can afford to have them come forward slightly, so it's not a big deal, but I would expand a little bit further. I wouldn't expand any further on the bottom. I'd just rebend the wires to allow the canines to come in. I'd build a new one, expand a bit more on that, and I would have the wire, hook around, so that as you expand, it kind of pushes everything out a little bit. And then, if you want, you can start to put brackets on the front four, and then when they get a bit straighter, you add the brackets onto the canines, and then that will align it up fairly quickly once you've got the room. But you don't want anything pushing these canines any further out. Okay.
Okay.
Yeah. And that should unravel itself. As far as the open bite that's developing, I think that you're just clashing here at the moment.
Okay.
And once you jump the bite, things might improve. Because I suspect that this is your only point of contact at the moment here.
Well, I think it's on the 6s too, and that's too bad that that one lateral shot went all weird. But
it's all right. But you can use this and you can intrude them, right? You can just bend these a little bit and push them in.
Okay.
So you have this wire, and you just activate this wire a little bit, and that intrudes the 6s a little bit. Yeah.
Okay.
Bend it the thickness of its wire each time they come in, and you'll get a fair amount of intrusion in a very short period of time. And then one thing that you've got to remember is this relationship you're seeing here is how she holds her jaws at rest all the time. That's how she got into the deep bite scenario. And this position where her tongue normally sits is how her tongue has always sat. Now, why is it out here now more than it used to be? Because that's the reason why you've got the open bite, right? The tongue's out here more. Well, guess what? You've got a block of plastic that's stopping her from going from where she normally goes. Yeah. So her normal resting position is here with her tongue where the block of plastic normally sits, yes?
Yep.
But now you've got a block of plastic where her tongue normally sits, other than just there. And guess what? Yeah. So get rid of the block of plastic, and you'll find that the back side, improves a bit, as it'll just get itself. It'll improve itself just by getting rid of the block of plastic.
Okay.
Good.
Yeah.
All right. It's I would put a new. I would make a brand new appliance rather than rather than muck around with it. You can make a new lower if you like, but or just give it a go at wire bending.
Yeah.
Have a go at bending these wires so that it's a nicer shape. Allows that keeps the incisors in the same position, but allows the canines to drift back in. Okay. And if that all falls apart, make a new one.
Okay.
And then, of course, be careful. These don't ever fall apart. The bottom ones always can fall apart.
Oh, okay.
No, it's the same screw. They tend not to fall apart, these types of screws, but some of them, if you overturn them, they fall apart.
I've had that happen with a different type of appliance.
Yeah. So it depends on the screw. Some screws have a lock that don't let them fall apart, but many screws fall apart.
Okay.
All right. Cool.
Simon, can you hear me?
Yes.
Yeah, so Cindy has a question about this case, about comment. The question is, would it be a bad idea to extract max primary canines to bring the U2s forward?
Which case? Oh, not her case.
No, Melanie's case, the one you were looking at. Is that the question, Melanie? Cindy?
Yeah, just that with the cat wires, you're limited because you can't bring the maxillary laterals forward because of the primary canines.
No. If you take the canines out, what happens if you take if you lose a primary canine? What happens? We don't have to think that far, do we, Cindy? All you have to do is look at your own case that you presented. What happens when you lose the primary canine too early?
You're decreasing the interarch space?
No. What's your eruption sequence for permanent teeth?
Oh, Okay. So for the upper, the permanent canine comes in after the premolar.
Yep. So what are you dealing with right now? That's a headache.
The same situation, the impaction of because of premolars move forward.
Yep. Because the 4s come out well ahead of the 3s, yes?
Right.
So if there's a space that you've created by taking out a canine, she's 8. Melanie, she's 8, right?
She's 9 now. She
9.
wants 8.
Okay. You've taken a canine 3 to 4 years before it was supposed to come out. What's that premolar going to do?
It's going to want to drift forward unless you try
It's going to say, thank you very much.
Yeah.
Thank you very much. I'll take that too. I'll take them both.
Okay.
And then what will happen at about 11?
Impact.
You'll say, hey, Simon, I've got this case where the whole arch has drifted forward.
Right. Yeah, that makes total sense.
Okay. So this is the thinking that I was talking to you about. All right. What's the, is there a week where you don't get from your orthodontic colleagues a letter saying, please extract primary canines to allow laterals to align?
Yeah.
Yeah. Now, you know what the thinking behind that is, right? It's called serial extraction, yeah?
Mm-hmm.
C's, D's, 4s.
Right.
Yeah, C, D, 4. That's a tried and tested method. Works beautifully. If all you care about is 24 teeth aligning nicely. And
Okay.
it's fine so long as that's your goal. If your goal is 24 really nicely aligned permanent dentition, put your plaster on the table type scenario, it's good. But if you start to pull teeth out without thinking about how it impacts everything else, then so our goal here is this: you want these together. You want these together, so you got a bit more room, and then you want more arch development. Then it'll all fall in.
But how do you get more AP growth with the appliance? You can't do that unless it's with posture.
Yeah. So what you got to do is you got to start. You need to tip these teeth forward, and then you need to train that tongue to go onto the palate. You know a Nance appliance.
Mm-hmm.
Right, you can put a little Nance button, and then you can put a spring, and you can push that forward, right? So, people like Galella and stuff, they have the growth appliance where they put that Nance appliance up there and a spring, and it pushes it all forward. Yeah. Well, guess what? This is. It's a built-in Nance appliance. So if you get your tongue up here, it's nature's Nance appliance, isn't it?
Mm-hmm.
So that's the goal. That's how you get AP. But it doesn't work so well in your patient because in your patient, his teeth aren't retroclined and his upper jaw is in a different time zone compared to the lower, right?
Yeah. Okay, thank you.
Okay, so I think that's good for Melanie. And then
Selena has to leave in about 10 minutes, right?
So we'll do Selena next.
Are you there, Selena?
Thank you.
Hello,
Yes.
Selena.
Hello.
Hello.
Hello. I'm good. You actually I only have 2 questions, and you kind of already answered the first one.
Uh-huh.
So
Okay.
the next one is very easy. I understand you give them retainers. Do you give them a retainer on the bottom as well?
Yes. Yep.
So does it do the same as the top one, like with the wires guiding?
Yeah, if you
everything the
need to
same?
have wires to guide you, you can. Generally, I don't need to guide as much in the lower.
Mm-hmm.
The lower seem to the one area that always needs guidance is the lower canines. They always erupt lingually. Almost always erupt lingually. So you need to make sure that your rest wire allows to guide them. So you've got to have less acrylic and more wire, so you can adjust that. Sometimes the premolars, sometimes the way I work, I create too much room, so I've got to bring the premolars forward. So I have a rest wire, but that's basically what we do with those ones.
Okay, I actually have another question if you can answer. I forgot to email you. For the cases that has on the top that has high canines, when we're expanding, we use the approximating wire to prevent the incisors from drifting back. So we have the increased arch length while we're expanding. Would you worry that the approximating wires are pushing on the laterals? Because if the canines are high, it might create reduction.
The approximating wires are not the same as brackets. When you have canines that run the risk of ectopically interrupting into the laterals, the rule is you've got to be very careful about putting fixed appliances on laterals, because it might lock them into the path of the erupting canine, and then you can have root resorption. But the approximating wires on laterals don't have that. It doesn't lock things rigidly. It's just a boundary line, and then the tooth can still shuffle. The teeth shuffle around themselves, and they look after themselves unless you hold them in a pace that doesn't allow them to move. So it's not the same concept, I don't think. I looked at your cases, and I just wanted to briefly go through them as well. So you've got a 9-year-old boy. So spacing between his teeth, slight, a slight, slightly weaker lower jaw. We've got a slightly deeper bite, but a normal kind of, not a heavy distorted malocclusion. The Boltons is, you just need to fiddle around with it a little bit more, so that you've got to, so that's not really quite right, but that's just playing around with it. They don't always line up the way they should. When you look at the analysis, he's a horizontal growth pattern, so much easier to manage. So not extreme, but just past the beginning of the hypos, but not extreme. Let's see. So not a difficult jaw relationship. We've got really excess spacing. We've got reasonable development of the arches, a deep bite. He does have decay, so that's the first priority. All right, so deal with primary care. So he's got lots of decay everywhere, so you want to manage that first, or get your general. You're the general dentist, so normally.
He's only referred to me for this. Another general dentist might.
Yeah, so refer him back. Don't do anything until they've fixed all this.
Okay. All
right, and as if a GP refers to you, don't ever do the restorative work.
Yeah.
Yeah. So send it back and say, hey, I'm going to help them with the ortho, but can you please manage the decay, get that sorted out, and then also make sure that he's on normal hygiene recall at least 2 to 3 times a year, please. All right. So make that very clear that it's up to them to manage that. So reasonably good arch development, but deep bite. So it tells us he's got his teeth apart a lot. But his tongue sits between the molars. But because he's division 1, he's flaring forward a little bit, we know that he has his tongue on top of all his lower teeth, all of them. So his tongue sits on top of all his lower teeth evenly.
Okay.
All right. So this case, the issue that you have is you've got a reasonably good developed lower arch. It's got a fairly flat curve of Wilson and Spay. You've got good spacing. This is just an orthodontic issue. All right. So, like, you know, there's not a lot of rationale to put a stage 1 upper or lower appliance into this boy. You know, what you could do is just bracket C to C on the top. You know, bracket high here and here, bracket really low here, here, and here, and here. And that will force those incisors back up. You might do an upper retainer with a cat wire so that you don't get too much retraction. All right. So just for the time it takes you to align those up, you would just consolidate all the spaces between the front teeth and leave the space between the lateral and the canine, and then just wait for, that'll take you all of, I don't know, 3 months, 4 months. And then you just wait for the teeth to come through, and they should come through okay. So what you want to do is you want to consolidate the front teeth, but you want to see if you can intrude them. So there's 2 ways you could do it. You could build a retainer, just clasp the E's, with acrylic on the surface, thin acrylic. You get your cat wire and you just intrude these, and they'll flare forward, but you'll reduce the deep bite. And then you put your brackets on and you retract them back and align them up, and that's the end of it. You just adjust the cat wire to allow you to control the amount of retraction that happens. Or you can just put the brackets on. I'm sure he'll be fine too. So bracket high here, bracket high here, and then, or you do a combination. Put the brackets on first. If it's running away from you, then put a retainer in the back and tie it and control it that way, whatever. Does that make sense?
Yes. So you reckon we should intrude the upper incisors, not the lower incisors? It's just I was not sure how he looks when he smiles.
Yeah, well, it just depends on the level of curve of Wilson or Spay. The level of curve of Spay, because you're missing a record image, right?
I don't have an open.
So I don't have an answer for you.
Yeah.
It's possible that he's got a deep. In that case, you just put a retainer and you intrude that.
Okay.
All right. Or you can do the same. You could. No, I wouldn't put brackets on the lower because he'll break them off every single time.
Yeah.
All right. So I would put a retainer and use the cat wire and just intrude. All right. If you don't have the control, you can put ledges of a blue composite on, and to help you intrude if you want, whatever. Okay, so this is your second case?
So there's a question from Judith about Selena's case.
Yes.
I think you said, aren't the upper lats peg, PEG?
Yeah, well, you make a call on that. You do the measurements, and if it is, then you can bond them, hide them, accept them.
Okay. Does that answer your question, Judith? And Judith had a question.
Yes.
I think Judith had another question before I missed. Do you activate the cat wires once a month? I think in reference to Melanie's case.
Just that I do it every time they come in.
Oh, okay. So every 2 weeks.
Just whenever, like it doesn't take very long to move teeth in children. So if you do it once a month, you do it every second visit, whatever. They're always a bit miserable after they leave on that visit because it hurts.
So just making sure that it's sort of like well adapted.
Yeah. Yeah. If it's well fitting, then I activate it. If it's not well fitting, I don't activate it.
Yep. Okay. Thank you.
All right. And then we have this case. Okay. So obviously heavily crowded, but also retruded. Okay, so this is a significant class 2. Yeah. Like this is like a surgical class 2. You can fit your whole thumb between the B point and A point here. Plus the it's bimaxillary protrusive in a significant class 2. It's a low angle case, and B is over 5 degrees and heavily crowded. So everything's, already doing the Superman trying to fly out of the mouth. But very narrow. Selena, normally with POS, the point where you put the upper is on the buccal cusp, the mesiobuccal cusp tip, because this is not a crossbite. But if you put that point in the central fossa, it becomes a crossbite. Yeah. All right. So what's the plan here, Selena?
I think she said she had to go to work now, so if you could
Okay.
just make any comments and she'll listen to the recording. Unless
This is a super difficult case. All right, because the teeth are almost off the bone already. And whenever you try to make room, you end up proclining teeth further. So this will end up, if we try to expand our way out of this, we're going to run into a lot of troubles. So this is a skeletal issue which the patient has dentally compensated for to survive. But anything you do will always make this worse. These are cases that you touch them and it gets worse, and now you own it. Now, what everyone else will do will extract, and then you'll end up with it'll look like someone's just taken a shovel and smacked her face in. And her nose will grow about twice as big. And that's just how it is. This is a surgical case or an orthotropic case. There's not much else that is going to work. Now, everyone else will try, and you will all want to try. And I don't know, maybe you'll get the teeth in, but it will not be an easy thing to do, and it will not end well. Because it's a basal bone issue. And everyone will focus on the orthodontic issue, and it'll just be it'll run a long time, and it'll be very disappointing for everyone.
So if I was the parent and I heard that, right, does that mean, what would you, if this person was your patient, what would you tell the parent?
Well, we would say that unfortunately this is a very, very strong malocclusion where the bones themselves are completely out. Now, in my practice, I deal with children whose imbalances are quite significant. So this is a normal type of person who would walk through my door, and I have a solution for this child because she's only 8. But it's a difficult process. There's lots of other simpler methods of treating, but they never end up, in my view, anywhere near as good as they can be. Because of what I do, good enough never is good enough, because the imbalances are so strong that getting a reasonable result still ends you up as an adult where your facial balance is still very wrong. So I tend not to aim low. I always try to aim as high as I possibly can. So let me tell you what I would do in these circumstances. Then I would talk about orthotropics. And if I wasn't capable of orthotropics, I would say I would talk about surgery. Right? But we can't do surgery on a child until they're 16 for a girl. So what we would have to do is we would look at the option of waiting until we're older so we can plan this carefully, or we would start by doing some expansion now to make room for the teeth, the minimum amount that we can get away with without any view of getting the teeth lined up, work on the posture, and again, plan for surgery when we're 16. And we would do the orthodontic tidy up, and then we would do the surgical workup at that point in time. Now, a lot of people will say, well, is there anything else we could do? Are there any other treatments that are possible? And then there are. You know, you can try to mask the difference. You might take some teeth out, you might pull them back in so that there's more room for what's left over. And a lot of orthodontists will do that. And it's a valid treatment so long as you understand the consequences of making everything smaller. We've got to understand that it's unlikely her tongue will have enough room now for everything to fit. If we take teeth out to try to make the ones at the front fit better, you'll get less room again. In my children, the ones who are medically compromised and who are quite almost disfigured by their imbalances, that's an unacceptable risk. But if your child has less medical health issues and you're happy with the facial development, then there are a lot of orthodontic specialists who will help you with the camouflage approach. Would you like me to talk more about how I treat in my practice, or would you like me to refer you to an orthodontist who might talk about some camouflage approaches or surgical approaches as well, because they might talk about that too?
Okay, so, well, in Selena's case, I think she messaged saying she's not here. Oh, Selena, are you still here, or you're working now? I think she's muted out, so she might be off to work, but...
But that's how, you know, that's how
you would. I mean, so you could handle this, but in her case, so she hasn't accepted that. I'm not 100% sure the situation. She'll have to.
Well, anything is possible so long as you set the finish point. Right? If you set the finish point is all I'm going to do is make some room so that you can have surgery later without compromise of having, you know, when you pull teeth out to make teeth fit, the surgery when you make a decision to do it 10 years later is compromised.
But let's say you don't have the 10 years experience or whatever you had, right? Let's say you're a relative beginner in this whole journey, and you get a client like this, and so let's say you haven't learned how to do the fancy advanced $20,000 cases like you know how to do now.
Yeah.
And I hear as a parent that surgery, and I freak out, right? So how do you allay their fears? And what if you don't know how to solve this problem? Let's say at your level of experience, what would you have said 5-10 years ago to that parent?
You have to say the same.
Which
you
is
have to recognize. See, the secret to success is recognizing the severity of the issue and saying this is a really, really, really difficult situation where the jaws are completely in the wrong place and the teeth don't fit. Now, this is beyond my capacity. I don't have the experience to deal with this. I don't have the knowledge. I don't have the skill set. This is a case that I would refer you for someone who has experience.
And so should I see an orthodontist?
Sure.
And what are they, and what's the, why did this happen to my child?
This is a developmental posture issue, and then we talk about how posture develops. And her case is she has kept her lips together, but her teeth apart, and her tongue is always wedged evenly between all her teeth.
So, I mean, keep that in simpler terms. I didn't quite follow that, all right? So the teeth were apart, so that resulted in it growing crooked. So do I improve?
Well, I mean, this would be the end. I mean, I don't have, I would spend the half an hour talking about all the things that I normally talk about with the posture and the mouth open.
The posture. So this is where, even though you couldn't, let's say you knew about the posture, you could at least give them some advice on the posture side of things, even though you couldn't help them, with
Yeah.
orthodontics.
Yeah.
But what simple tips can you try to encourage them to? This is like get the book and follow these exercises, right? To at least try to.
Yeah.
damage
Obviously, the goal is to try and keep the mouth closed, but it's impossible. You can't manage someone else's child who's not under your care. So it's just one of those things that this is more than I can handle. I'm sorry, I can't help you. Like, it's just the nature. If you try to help someone, it's like saying, look, I've got to get a trailer full of horses across the mountains by tomorrow. All right? If I don't, the horses are going to die. And can you drive them across? And you said, but I don't have a truck license and I've never driven.
Okay, so let's assume that, all right, you don't have the skill set. And what's generally going to happen in a normal situation like this? So the parent goes, I'm freaking out. You're saying he needs surgery. If I go see an orthodontist, what are they going to do? Pull a few teeth out and then put braces on in about 4 years, 5 years when they're a teenager?
Yeah.
Then can I avoid surgery at that point? Can I just go with braces?
Sure. If as I said, you can hide it. So we talked about camouflage, right? You can hide it. You can hide it by taking some teeth out to hide it.
Okay. And how would that affect? But then what are the consequences of that? Well, versus doing surgery?
Well, that's the whole point of, that's what we've been trying to spend the last 5 days of training to help people understand the consequence of having less room is that you have less room, and there's a potential trickle back effect. If your teeth don't fit and you take some teeth out, you have less room, so your tongue might not fit. And if your tongue doesn't fit because you've been hanging your mouth open, and you hang your mouth open even more, then it's got to go somewhere, and sometimes it can end up in the back of your throat.
I'm just from a lay person's point of view. When I hear surgery, because I wasn't even aware that kids need surgery because of teeth. I just think orthodontic work, right? We don't even know, most parents aren't even aware that the kids have to go through. Some kids have to go through surgery to fix whatever.
Yeah, but everyone is aware that sometimes you have to pull teeth out for your braces, right?
Sure. That's the general.
So my question to you is, you understand that pulling a tooth out is a surgical procedure, yeah?
Is that what you mean? Okay, just purely the surgery. When you say go through surgery.
Well, there's different grades of surgery, isn't it? Right. So taking a mole off your back is a surgical procedure. Neurosurgery, by opening up your brain.
Okay. So that
cancer is surgery.
So it's interesting that when you mention the word surgery, versus pulling out teeth, there's a difference in the way a parent who may not, you guys use that term because it's the technical term, I guess, for pulling out teeth.
No, we use that term because this is a political conditioning. It's called brainwashing. Right? So it tells you that pulling a tooth out is not significant. It trains you to believe that pulling a tooth out is okay. It trains you to believe that it's only a very simple procedure that is done every day for millions of people, and there's no dramas whatsoever. But let me ask you this. Would you accept me pulling a tooth out from you without numbing you up first?
Not, right? Anyway,
so just because we have the technology to make it less painful doesn't mean that it isn't ripping part of you out from your body. And what I'm trying to teach people is this. Surgery is surgery. All
But
right?
we are
Whether
going to,
it's pulling a tooth out or ripping your jaws apart, it's still surgery. It's still the same spectrum. What we've got to determine is that something that we're prepared to do to make our teeth straighter? Because at the end of the day, she will not die from crooked teeth. If you don't want to do the surgery, accept the crooked teeth. It's not the end of the world.
yeah, I mean,
But
yeah,
if you want straight teeth, there's a price to pay. And the question is, how many straight teeth do you want? How straight do you want your jaws? If you want more teeth straightened, then you have to do more. If you're happy for just some of the teeth to be straighter, then it's simpler. So if you don't want to do major surgery, then you have to do minor surgery. If you don't want to do minor surgery, just accept that the teeth are crooked.
So Kathy has a question, referral to orthotropist. Can you explain concept goals with bio-block approach for Selena's surgical case?
The problem is no, because I don't actually believe that there are any orthotropists out there who are worth referring to. There's less than a handful in the universe. So I would rather drive a patient to do surgery properly, because there's a lot more surgeons out there who know what they're doing than there are orthotropists out there who know what they're doing. Or accept what you have. Just accept it. Right? It's no one dies from crooked teeth, honestly. It's just an aesthetic issue. But if you try to straighten crooked teeth, you can create a worse scenario if you compromise the growth and development. Most people will be able to tolerate their imperfections. But if you drive your own system into that body to make the teeth straighter and don't understand how that affects the impact of the growth, then you can tip a fragile ecosystem over the edge. So my thought always is, if I can't do orthotropics, and if they're not prepared to do surgery, and it is a surgical case, I would say don't do anything. Accept it. Move on.
Okay, this is Larry's question next. We have quite a few more questions.
All right, 9-year-old boy. All right, so Larry's done the workup. So worried about crowding at the front. He checked the mu indicator and it seems to be okay. It's rare that it would be okay and have crowding, but we'll see. The lower indicator is much higher, which is consistent with having the mouth open more. So it's possible if they have a specific tongue posture that supports the upper jaw but doesn't allow the bottom jaw, such as midlines, overjet. So overjet is 6 mil, overbite is 3. So when you're talking about a high overjet, it's very rare that the indicator line is going to be close to ideal. We're looking at whether the patient can move left and right, back and forth, deviations. Let's see, the nose works. Some movement in the facial habits. Didn't check the joints. The tone is good, but a big tongue. Okay, let's have a look. So no sleep disorder issues noted. All right, so we have a boy. So we're looking for fairly even lip tone and not huge chubby cheeks. He smiles and his teeth are through. Maybe a bit narrow on the left. But he knows how to smile. So lips are full. slightly chubbier cheeks than we would like, slightly weaker jaw, but within a normal range. Yeah, we want cellar and nason and frontal, and sometimes you got to muck around with it a little bit to get it right. Okay, so one of the things that is very common for children is when they have the x-ray done, their mouth is open. And the moment that happens, the Ceph analysis becomes incorrect because you're more class 2 than you should be. All right, so you hang your mouth open, you're going to be more class 2. You're going to be more vertical. So it throws the measurements out. But this is very, very, very typical. Most kids don't know how to stay closed in a still position. So his lips are together, his teeth are apart, and that's probably how he rests all the time. All right, so this here internally is this, hence the weaker lower jaw. Y-axis, so analysis not done, but it's just a quick y-axis. But again, yeah, so y-axis, so it's not quite correct because the mouth is open. In a closed position, we see he's got a crossbite. So this side is nice, this side is not. Hygiene needs work. So this side is almost ideal. This side is in crossbite. We're tight for space for the canines for the future. And as expected, it's under the 38 that we would want in order to get everything to fit. But his, everything kind of fits reasonably well in the lower. And that's consistent with what? It's consistent with the tongue driving more of a growth pattern. So no major issues other than a crossbite. So good muscle tone and large buccinata, tongue off the palate, upper and not far from ideal. Less lips, part, upper canine, crossbite, expand, crossbite, equilibrate, primary canines, go back. So did you want to, Larry, are you there?
Yes, I am.
Run through your thinking and I'll tell you mine.
Basically, you have said whatever that I have thought of, and I'm asking if there's any other issues that I should be aware of in this particular case.
These cases, if you expand, the crossbite will remain and the other side will blow out into a scissors bite.
Okay.
So we have to modify the expansion to prevent that from happening. So in this circumstance, my expansion will be focused on just the upper because the lower is fairly nice, yeah?
Right.
So if you got that to cross over maybe another, I don't know, 4 mils, all right, 5 mils, then you would have a really nice scenario.
Okay.
So what we would do is we would look at a crossbite flange.
Yes. Yes.
So we would.
That's the crossbite correction modification to the appliance that we're thinking of.
Absolutely. So we would look at a plate that we would start just with the upper appliance.
Yep.
And we would. Where are we? Yeah.
Yep.
We would just have an upper appliance, and then we would drop a flange down on
to the right hand side.
To his right, so just like this boy, yeah.
Yes.
So this is obviously the opposite side, but it would look like that.
Yep.
But you would want it for him on this side.
Yep.
And then when we look at his arch, you'll see it's all squashed Which side is squashed in? No, is that flipped over? I think that's flipped over.
Yes, this is flipped over. Yes, this is the mirror image.
Yeah. So one thing that I ask you guys to really make a big effort to do, flip your images over
Okay, got it.
so that you're looking as if you were in the mouth looking. So that you know that this is, oh no, you didn't use a mirror, so you just retracted, so that keeps it simple. But if you have a mirror image, make sure that your image is correct, as if you were sitting on the tongue looking up,
Yep.
and not in a mirror.
Yep, sorry about that.
Yeah. No, it's just something that I'm always looking out for it because I know people don't do it, but it can create dramas for you when you're designing appliances and things.
Yep,
Yeah.
understandable.
Because in this circumstance, it looks like the narrow side is here, yes,
Yep.
and the wide side is here,
Yeah.
which it is. So your design would say, oh, I would want to put the flange on the wide side, and then I could blow that one out, right? And then your appliance comes back and you don't think too much about it, and then what's going to happen? You're going to lock your crossbite, and then you're going to force the scissors bite.
How about the lower primary canines? Do we need a bit more space for the eventual eruption of the adult canines?
Yeah, so what we would do is correct the crossbite first.
Uh-huh.
Yeah, correct the crossbite. You mentioned about equilibration, so it depends. You know, you'd want to take the tip off if it gets in the way. So correct the crossbite first, and then evaluate to see what space issues you might have for the future. And then you've got to estimate, will I get my canine, my premolar, you know, do I have enough leeway space to make up the difference? And if I don't, then what we would do is we would determine where are we now with our width, and do we go a little bit wider and then start expanding the lower as well? And then do we activate the cat wires and procline them slightly to make room for the canines? So you play around with it.
Okay.
All right. So he's not a 6mm overjet. Okay. A 6mm overjet is a class 2. This is not a class 2. So this is more, I don't know, 3-4mm. So you can afford to procline these teeth very slightly because the lower incisors in particular are a little bit retroclined, and there's not enough room. But you've got to, you know, you have to estimate how much leeway you have, and it's usually if the canine is crowded, it's not enough. But because you've got a deep bite, you can get away with it a little bit. So you can procline them very slightly to make room for the canines. And they'll crowd back anyway later in the future. So, but yeah, so I would do the crossbite correction first, then reevaluate where you are when you are in a good relationship and make a decision about whether you're going to expand further. And if you are, then expand further on the upper, and then expand on the lower. And then activate the cat wires very slightly so that you are trending towards an overbite relationship that's closer to maybe 1 or 2 mils. And then that will give you enough room for the canines.
I see. So roughly how long will it take for the crossbite correction to happen?
It will probably take about, well, it's 1mm every 10 days-ish.
Okay.
So 3mm in a month.
Okay.
And you might only need 6 mils, 3 mils, 4 mils. So it might be done in 6 weeks, right?
Okay.
If it's running smoothly, it'll be done in 6 weeks. And then what you need to do at that point is to see where your bite is relative to the lower. And then you can make a decision about whether you want more lower expansion. You don't really need much more lower expansion, but it wouldn't hurt for the incisors to come forward a bit, right?
Yeah. Then when the crossbite correction has been achieved, then the flange gets cut off, and you see.
I would keep it there for a while because habits are difficult to correct. So I'll just leave it passive for a few months Just let him wear it. He's got to eat with it, yeah?
Passive means you're not activating the expansion screw?
Yeah. Just wear it full time, eat with it, but don't turn it.
So it's like meant to be a retainer appliance?
Yeah. Yeah.
For how long? Before if I decide to expand it further, when should I commence that?
Then you just got to make a judgment call as to how much room you need once you correct the crossbite.
Yep. If it comes to the situation where I think I need more space and more expansion,
Or if you need more
when can I-
space, you can just keep going, right?
and if I keep going, I can cut off the flange, the crossbite flange?
Yes. Yeah. Yeah.
Okay, so that means if no further expansion is needed after crossbite correction, I just leave the flange there for a few months and just leave the device there as a retainer. Otherwise, if I need further expansion, I can cut off the flange and go straight ahead with the upper and lower expansion appliances.
Yeah, exactly.
All right, right. That clears up a lot of.
And then, of course, train with the posture, because this is a postural issue. So how did this come about? He's got his teeth apart all the time and his tongue's wedged to one side. That's it. Or he sleeps on one side with his fist under the pillow.
Under the pillow. Yep. His mother says that he tends to sleep on one side with his mouth slightly open.
Yep, and he's got his hand underneath his face, either under his face directly or under his pillow.
So in this case here, he will typically be sleeping on his left.
Yeah.
Okay.
So the goal is he's allowed to sleep on his left, but he's got to get his hands from under his face.
I see. Right.
All right, guaranteed 100%. He's got his hand underneath his face.
Any practical tips on preventing to prevent his hand from getting under his face when he's sleeping?
No, this is just a conscious activity, but that's why you got to keep the flange there for a longer.
Right. And after the expansion has been completed, how to finish up with the case?
How old?
He is 9
9.
and 2 months.
So I just keep him in retainers and hold him. Just wear it at night.
When to full-time wear for at least how long? Until he's able to master all the go packs and
Yes.
go packs.
Yeah. So I'd keep him. You know, I'd run this treatment at least 6 to 9 months, and then go to nighttime after that, and then just keep him there, and because it will relapse back.
Okay. All right.
Yeah.
Got it.
But if you look at his positions, you can't flare his incisors out too much further. Yeah.
Would there be some form of mandibular protrusion after when he does all the go packs and go packs exercises? So his teeth will mesh up together well, and the mandible somehow walks forwards.
Well, it's not going to walk forward if the teeth are in contact. So what you want is for both jaws to rotate forward.
Yeah, that's right. So there's no mandibular rotation, but can we get away with some enamel reduction on his primary teeth?
Well, I don't think there's any need for that.
Okay. So
Yeah.
just maintain the mandibular position.
Yeah, just teach him to keep his teeth lightly together, and the rest will kind of work itself out.
Got it. Thanks so much.
Cool. Okay. Ruyan, 2 PowerPoints. So we have a 7-year-old. So this is a case that's already in treatment. So we'll just go through the images and then we'll work it out from there. So this is presenting. So obviously we have a very pronounced upper lip. Yeah, it's these overlays, you just gotta fiddle, just keep fiddling. Try to aim to get the frontal lines to marry up, and then try to get as best you can the cellar and the nasion. Doesn't always work out. Right, so we have quite an A point that's well ahead of the forehead, and a B point that's also ahead of the forehead. A and B is 3, and it's a low angle case. So not a major skeletal issue. It's quite possibly related to the incisors. But we have a deep bite, and we have a very open, we have a heavy curve of Wilson, and not a lot of tongue space. So just try to get as much as possible a right angle view to the 4s or the Ds, rather than coming out towards the laterals of the canines. We want as close as possible to a profile. Helps us understand what the relationship is. So really big teeth, like really, really, really big teeth, coming through in a very, very small space. And we had premature loss of the E's. A bit of movement in the X-ray. Hard to tell if there are any. So what we have to make sure is if there's any missing teeth in this region, whether any of the laterals are missing. So the 6s have tipped over. Mum was concerned about the front teeth, not enough room, and a very deep bite. So over eruption of the B and the C on that left side. The loss of ease. Try to reduce the deep bite. So this was treated with the MyBrace system. So this is the start. And then how many months? 1 month? 1 month. And then month 4. So we've got spacing now in the lower incisors, but we're edge to edge and in crossbite, and the centrals are coming back. So they've gone from division 1 to straight up and down to division 2, and the lowers have come forward. So we've gone from a division 1 to a division 2. But obviously the profile looks much nicer. Brought the lips back in. But we've lengthened the face. Patient's been wearing the MyBrace nightly, able to breathe through her nose. Parents say that the MyBrace stays in the mouth, but her lips are apart when she sleeps. When I review her after the lockdown, she's developed a posterior open bite and her anterior teeth are edge to edge. What can I do to stabilize her posterior bite? And how do we open up space for the 5s? All right, so Are you there, Rian?
She had to go to work.
Okay.
So just do your best to give your thoughts on this one.
Okay. So the correction for what has happened has been to retract the incisors on the uppers and to kind of blow forward the lower incisors. So, of course, the open bite is because of the edge-to-edge relationship. So she's in crossbite. So she can't actually close down anymore because she's in a crossbite and edge-to-edge relationship. So if we leave it as it is, then her teeth will erupt into place and she'll get locked into a edge-to-edge position. And for people who don't believe that you can create a class 3, well, you can, right? You can create a class 3, you can create a pseudo class 3, and you can lock the relationship with the jaws in place. But what tends to happen is you get lengthening of the face and both jaws drop down and back. So you end up with a class 3 that is a more vertical, and the upper jaw kind of falls back to meet a lower jaw that's protruded slightly forward. So it gets very messy, and what we will need to do in order to unravel it is we've got to look at some expansion and getting the incisors back into a better relationship, so not a division 2 relationship. We need the expansion because we don't have enough room for the lateral, and proclining the incisors also gives you a little bit more room. We will be able to control it so it doesn't end up in the weird scenario. But this is also a lip tone issue, so keeping the lips together improves their appearance as well. With the lower, we would probably want to allow them to relapse back slightly, but we want to open up space. So I would expand the upper, create a better incisal inclination, stop whatever we're doing on the lower and let those incisors fall back in a little bit. Then we would create a sagittal appliance with screws on the sides and then reopen the E space. And it should all work itself out from there. And then, of course, work on the posture and the go pecs and go fecs. Now, how did this all come about? The My Brace does that. It's if you wear the My Brace but you don't keep your lips together, then this is what happens. You get a retraction of the upper, but you can sometimes get the lowers coming forward. It's just the nature of the appliance. So how would they unravel that? I don't know. Once you're in a pseudo crossbite, you'd need to do something. I don't know. They have different systems, so she would have to follow their advice on how to manage that. But that's what I would do in this case.
Simon, can I ask you a question about this case really quick?
Yes.
When you're making that appliance to distalize the lower sixes, was it that you're doing it one side first and then the other versus doing both at the same time?
Same. Do it at the same time. Yeah, so I'd clasp the Ds and the 6s and the screws on either side, and then just have them both activated at the same time. It works surprisingly well with very, very few side issues. Like they never get sore. Very rare do they get sore. There's just, it works really, really easy because most of it's tipping. We're just trying to tip it back.
Do you think in this case she would maybe put in a labial bow or something for the lower incisors because they're so you don't want
You could, for sure, you could. You just have a little bow and then you can control what happens from there. You don't want to be, you'd let them relapse back first on their own. And it would, unless the crossbite here creates the drama. So if the crossbite there creates the drama, then I'd just take a burr and I'd grind down that primary B and eliminate the crossbite. So I'll just take a burr and grind it. Or as I'm expanding, I'd push it forward a bit. So I'll do that first. If that's not enough, then I'd grind it. So the cat wire will unravel that crossbite quickly, especially if you stop wearing the myo brace, then they'll fall back in a little bit. So it kind of, it unravels itself is basically what I'm saying.
Okay.
All right, and then the other one.
Got a question from Miller. Do you want to? Are you there, Miller?
Yes, I am.
Yeah, go ahead.
Look, I just wanted to clarify design of this lingual flange when, in the previous case for this unilateral crossbite correction.
Yep.
What instructions do you give to technician?
Just crossbite flange is what I asked from Enrico because we've been doing it for so long. But the design has to be, it can't be straight up and down. It has to be angled very slightly in. It sits, it's about 1 centimeter and it coincides with the E.
Right.
This is one I hand built myself, but that's how they build it for you. So it's got to be slight angle because it's got to sit. It can't go up and down because it'll hit the alveolar bone. So it's got to be angled to deflect slightly away from the soft tissue. This is just, it only touches the teeth. It doesn't touch the soft tissue. Right? It doesn't touch the inner surface. Right. It's about 1 centimeter in length. And what they have to do is they have to articulate the two models and then they have to build it using an articulated model.
Right. Right. So, and you start with this flange from the very beginning. You do not add it later on.
No, in a crossbite that's locked, like what it was with Larry's case, you would definitely do it straight away. Although in this circumstance here, I forgot to ask for it.
Right.
Yeah, I forgot to ask for it, and I thought, oh damn. So I just built it with the I use Cool Liner, which is the self-cure acrylic.
Yep.
So I just built it at the insert. You can see I haven't started expanding. Mm-hmm. And then you can use it from the beginning. But yes, I'd use it from the beginning.
Do you ever use it bilaterally?
No.
No?
No. Well, kind of yes, in that that becomes what Mike Mew has termed a hybrid 5-lock, where you're expanding the lower arch at the same time. And I do that routinely with my orthotropic cases in what we call the hard locks, where I add acrylic all the time, and I use acrylic to expand the lower arch. Mm-hmm. So you can, I mean, I suppose you can, if they're tipped a little bit, but it makes it really, the reason why I don't is these appliances, the children eat in them.
I see.
All right, and if you put it on both sides, they can't eat.
Right. Right. Okay.
And you can only use the upper on its own. You can't have a lower at the same time.
Right. I see. I see. Okay. Thank you.
Good. All right, so really has a second case. Okay, so this is a boy who has incredibly strong and active mentalis muscle and tight lips, and transitioning into early mixed dentition. But we're definitely a vertical growth pattern, a very high angle child. And these figures are not relevant because the mouth is open. You see the teeth are apart. So this is showing more class 2 than it should. But I suspect this is a high angle 3. So we've got, if this was a ski run, it would be a double black diamond. And we unfortunately can't use these figures other than the upper relationship you can use. So, we're on the deficient side in the maxilla, which is a clue. But we're also, you can't, the S and B is not correct because the mouth is open, and the A and B is not correct because the mouth is open. And even the FMA is not correct because the mouth is open. But even if it was closed, it would still be far too high. And then in maximum intercuspization, we can see that we've got new teeth coming through and we're tight for space. And it appears that the lower incisors are retroclined, and it's possible that we're edge to edge. Where are we? We're class 1 in our molars. But again, when you're coming in from when the lateral is the centered tooth, then you're not giving a profile. Okay, so not enough room, so it needs a lot more room. We can see that we have a retruded maxillary complex here. So it's like a wall, a vertical wall down. And we're a bit tight for space. The two arches don't really marry up well. We're going to be tight for, so the laterals are already completely twisted around, and the canines and the laterals are stacked on top of each other. So we need a lot more room for everything to fit. Not sure what's going on here. I think movement. But this is a boy that never has his mouth closed, so it's not surprising. Patient came in with his parents, routine check, noted mouth breather, had mild crowding. When asked, he had allergy issues when they were younger. They've been using nasal lavage. Should be worth looking at early intervention. They returned in 2000, and 6 months later, they returned. And he is edge to edge. So teeth still erupting. And there's not enough room, of course. Lower arch is slightly better, but the bite relationship at the back is okay. Chorovitor looks like he's more hyperdivergent, not keen to see the end teeth. these are really, 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 really tough cases because they are hyperdivergent. So this just gets worse generally. And if he's a class 3 hyperdivergent, then it's probably the most difficult of all cases to treat. So this is very much more common in Asian populations, Oriental Asian populations, much more so. And this is a case that I'm probably going to spend a bit of time talking about in the June, in 2 weeks, when we talk about growth and we talk about class 3. So I'm going to talk, I'm going to have a whole module on class 3. So I'm going to go through this case, but this is a really potentially a very difficult case depending on whether his nose continues not to work or not. So if his nose becomes clear and you can train him to keep his mouth closed, then it won't get a lot worse. If nothing changes, it will just get worse. So there's great risks involved into treating these cases. The other thing is everything you do makes things more vertical. So if you expand, you have to go in and out real quick, because if you put plastic in his mouth and his nose doesn't work and he's already got his mouth open, his mouth is going to open even more and it will get worse. You'll get the teeth in, but they'll never meet in the middle. And on the next session, the next formal session of the phase 2, I'm going to show you cases that I'm struggling with to control in who presented pretty much exactly like this boy did, because of the nature of hyperdivergent class 3s. Okay, so this is a very tough case, especially because the parents don't care that his nose doesn't work. Parents not keen in seeing the ENT again. So this is a danger, Will Robinson type case. Judith, I think I wasn't sure about the Dropbox links, but I downloaded your cases, so I'll use the downloads instead. Judith.
Yep.
Actually, Judith has updated stuff.
Yeah, I've got the updated ones, but I couldn't, when I saw it before, I couldn't bring it up. Okay, so 5-year-old, some allergies, we had a cross bite, and you did some equilibration, I think, yeah? And dad has a very poor growth pattern and wants his daughter to have a better life. And we have, we're waiting for an evaluation by the ENT, but not a major sleep disorder breathing child, I suspect. All right, so we have basically a resting posture and a squarer face. So not common for these children to have sleep disorder breathing to the same level. That usually brings on a concern from everyone. We have a frowny face when we close, so we know that the teeth are apart pretty much all the time. We have fairly strong muscle tone, but we just hang our mouth open and we use our facial muscles a lot more than we use our elevator muscles. All right, so we're tight for space. So the main thing is that we don't have enough room. And again, just, spend some time and practice using the, you saw my talk about using the mirrors on the models on the table.
Yes. Yes.
Yeah. So have you guys had a chance to practice? Has anyone been practiced using the mirrors on the models on the table?
I haven't, but I will do it now.
Yeah. Try, use it. It's a good tip. it works. It doesn't work if you don't use it.
I think Simon, we're trying to train my team to do the side with the mirrors that you're talking about, and for the little kids, we're having a hard time,
Yes.
Yes. So
kind of
you need to have either very small mirrors or just use a full retractor. Use you can use the retractors that allow you to direct images rather than the mirrors. So you can get very small, narrow side mirrors.
Okay.
So I have those for the little ones.
Okay.
But you can. I think Larry showed his case. Larry's case had the. You can use these ones, like Larry showed. Yeah. So just use the retractors themselves to pull.
Oh,
cheek. Yeah. Right. So use whatever you use anything. So long as you get that view, it doesn't really matter how you do it. So experiment. Buy some of these retractors that allow you a direct view, and buy some really skinny lateral view mirrors. And some of your staff will prefer this, and the others will prefer the other one. But have it all available, and just experiment a bit. So we've got a really, really, really high palate, but a broad palate. So what that tells us is that we've always got our teeth apart, but our tongue is always wedged between the teeth. So the tongue sits kind of, along this ridge. And then you end up with typically that type of relationship where you have a class 1-ish relationship because the jaws are held about the same, but you have a much more vertical growth pattern, but the teeth meet, but you always have a super high palate because the tongue never lives up there. And you also have a situation where there's never enough development because the tongue lives between the teeth. And it's very important, very, very important to take images with the teeth apart as well as together, because that gives you a better idea of where the tongue lives normally. Yeah, so tight for space. Even though there's a lot of space, we're still tight for space because Oriental children have enormous incisors. As a general rule, and no x-rays, so I can't tell.
No, because, well, I don't normally take x-rays for under 6, but I mean, if you think that's necessary, then I will organize them.
Do you know if there are any permanent teeth missing?
No, we don't. We don't know.
So.
Okay. Easy done. Yep.
Yeah. So here's the thing, child comes into the emergency room and their arm looks bent, right? Like bent. She says it doesn't hurt. What's the doctor going to ask for as the first thing after the history?
Yes.
They ask for an x-ray, right?
Yes.
And, mom says, oh, I think she's too young for x-rays. And then you can say what? Oh, obviously she's too young for treatment. Come back when you're ready.
Sure.
So, I mean, some kids you can't because they just don't stop moving. They physically, you physically can't. But it's, you make that decision after you can't. All right, so collect the rest of the records, and then we'll talk some more.
We'll do.
Yeah.
Yep.
All right, and then the second one, we have a concern about underbite.
Yeah, so this one I only saw yesterday, so I apologize for the poor quality of the data collection. This is at the new practice that I started at. So we're still getting used to the nurse and the patient flow, etc. So
Okay,
you'll
so
find that the standard of the records are a little bit lacking. So,
okay, so gags easily.
yeah.
The nose is a bit blocked. Is that habitually blocked or is it just sometimes blocked?
That's when I tested it.
Oh yeah. Okay. So sometimes snores.
They were not aware of any blockages,
Sure.
and mom didn't notice the open mouth posture only until I pointed that
Yeah.
out yesterday.
Yeah, fair enough. Most people don't. Most people are not aware. Okay, so what's going on with her lips? So this is a child who licks their lips.
The lips were fairly dry, and she had 99% of the lips apart yesterday.
Yeah. So
They're
she
just
licks her
hanging
lips.
open.
Right. So they
Okay.
lick. These are, you can see the redness around the lips. So
Oh,
that's
yeah,
from
yeah, yeah.
saliva. So she's
Okay.
a child that licks her lips all the time.
Right.
This is something to be aware of because
Yeah.
they can have problems as far as their dentition. If they lick the bottom lip all the time, then they'll drive a class 3. It's just weird things can happen.
Mm-hmm.
So when she smiles, we can see that she's kind of class 3. And her posture changes depending on the position that she's in. So it's an inconsistent closed position.
Yes, you would probably notice from the x-ray as well. When we did the trial run, she had the teeth closed, but then when I hit the button, she had it apart.
So
then
many of the younger children in particular, they've never spent a day in their life with their mouth fully closed. And asking them to do so is like asking them to jump and slam dunk a basketball.
Okay.
They'll give it a go and then they'll lose interest. And that's just, that's just what we're dealing with. In the younger kids, they have no body control whatsoever. I mean, some of them, you wonder how they even stand up straight, because most of them don't. Most of them are leaning against the wall as you're chatting to them. So they're very floppy. A lot of kids are really, really floppy. And part of what we're trying to do is create a little bit of physical tone in their body. So that's just something that you have to bring to the attention of the parents because they're completely oblivious to it. And also for your own attention. So she's got her mouth open, but there's a lot of mandible. Right? There's a lot of mandible. Yeah. Like this, she's only 7, but the density of that mandible, the height of that mandible tells us that, there's a lot of mandible growth happening. And children who have their mouth open and who have a low tongue position, it stimulates a lot of mandibular growth. And if the nose doesn't work on top, then the maxillary growth stops keeping pace with it. And we're, class 3. So the question that we have to determine is, are we a skeletal morphological 3 or are we a functional 3, a pseudo 3? And
I haven't done the analysis, so again, I apologize.
yeah, well, you can't because the mouth is open in the x-ray. But
would you redo them, Simon? Or
yes, I would.
Okay. Yep. Done.
I would if they agree to treatment.
Yes. Okay. Yep. Sure. Yeah. It did appear difficult to me, but I thought I would get your opinion as well.
Yeah. So the other thing is, because we're erupting into a cross bite, she's not, at some point in a very, very soon, she's going to stop keeping her teeth apart even when she's chewing. All right. And then what she's going to do is she's going to posture forward because it's going to be too sore to bite here. And then you're going to see the acceleration of a potentially functional 3 into a morphological 3. So one of the things that you want to do is, start taking history on. Is there any class 3s in this one?
The intermolar width was 37.1.
Okay. But you know, what we've got to determine is, are there any relatives in the family with class 3, things like that, right?
They said no,
Mm-hmm.
but I didn't ask for extended family, just immediate
Sure.
family.
Oh, that's fine. All right.
And she was a little bit out of the focal trough.
Yeah. So everything's a bit blurry, but you can still count the teeth and whatnot.
Mhm.
So ENT referral, then upper stage 1, the bow or a face pull, brackets, then depends on what the laterals do. And lower stage 1, partial brackets, lower tongue tie release once the space is created. Would you intrude the upper sixes to allow auto rotation? Is this built into the design, or do you have to wait? Option 2 is bonded hyrax and card bow, then upper and lower 2x4, and then just the GoPex. Well, GoPex doesn't change, only the GoFex changes.
Right.
GoPex is about teeth together and lips together. GoFex is about tongue on the roof. So
Oh, I thought there was the tongue push-up as well, that you have to do 10 reps.
Yeah, that was the early GoPex, and it's more, you know, as you can understand. It's
So,
more, but you can still do it. A Tyrex, it doesn't. You see some kids and
okay,
they indents of
you
their
can still
Hyrax.
do it. Okay, yep, sure.
So the issue, of course, is what are we going to do here? So this is a low angle case, even though it looks like a high angle, but because the
Yes.
teeth are apart, yeah. So this is more of a low angle. So that's just eyeballing it, but it's probably fairly close. So pulling forward will help. Yeah, so you want to pull forward, but what you could do is you could start expanding first, and then use the cat wires to jump the bite, so that the incisors cross back into the right relationship, and then work on GoPex, and then pull. All right, but once you have the right relationship, then you can determine where the mandible and the maxilla sit against each other. Because if it's a pseudo class 3, you don't really need to pull forward. You just need to get them to stay closed. Yeah.
So, sorry, I may have misunderstood. So you would start expanding and then decide whether you need to pull forward as well? Or do you
Yeah, you
start
want
both
to.
together?
You haven't determined whether this is a morphological or a
Right.
skeletal,
Yep. Okay. Sure.
or a functional class 3. If
Mhm.
you're a functional class 3, then all you need to do is correct the crossbite.
Okay.
If you're in class 1, why would you want to pull into a class 2? If the issue is that it was just a functional shift. So you have the other benefit once you get a good centric on the CBCTs, you can check the condyle position, right?
Yes.
All right. So so that's first you got to determine what you have. So you protract forward if you're a skeletal class 3. If you're a high angle skeletal class 3, then you're going to struggle. Now, if you want to intrude the 6s, you have to think, well, why would I intrude 6s? Why would I want auto rotation? What does auto rotation do?
Well, I would like to help with how the you know how there's the antigonial notch. I would like to help sort of reduce that mandible from running away from the maxilla.
Well, here's the thing. Auto rotation reduces class 2, yes?
Yes.
So what are you worried about in this child? What skeletal relationship are you concerned about?
Well, I actually was hoping that given that she's still 7, I can help with the maxilla going forward, and then helping the mandible to also be in a more balanced proportion. Because at
Okay,
the
so
moment she looks like that, case that you describe as being looking like a monkey, and to me she's kind of heading that way.
no, she doesn't look like
No?
that.
Okay.
The other one did,
Okay.
but you can't tell because you don't have a relationship. Right? You don't have a true relationship to compare.
Right. So you would say that maybe
So
we don't.
the monkey look is bimaxillary protrusive, bimaxillary dental protrusive.
Mm-hmm.
Well, this is not the case. So if you pull forward and then you intrude,
Mm-hmm.
all right. So how long do you intend for this case to go on? And then what's your game plan? Because
Well,
auto rotation, if you intrude the 6s, then what?
then the mandible will close more,
How?
which means
No,
we're
but
gonna
how?
have.
But how does it close more? Because you've got your
Oh,
E's still in normal contact, and your D's are still in
right.
normal contact, and your C's are still in normal contact. So what does intruding the 6s do for you?
Yeah, well, that was kind of a question, because I was reading the lecture notes where you
Mm-hmm.
incorporate the D&E extraction down the track.
Yeah.
And that's why I kind of like put a question mark there. Maybe this is too early to do so.
So when would I see? I would take the D's and E's out if I was going to add around 11
Yeah,
or 12 when
yeah,
the D's start to fall out.
yeah,
So you're 7
yeah,
and you intrude the 6.
yeah.
You
So
got
that's why,
you
yeah.
got 6 years to hold it. So you got to hold everything for the next 6 years.
Yeah. So that means that's probably not a suitable solution for this one, right? Yeah.
Yeah.
So yeah, I didn't have, I suppose, more comprehensive understanding of what I was reading in the handout. That's why I put it there. So
Okay.
yeah. But I suppose my main concern was the maxilla looks a little bit borderline to me,
Yeah.
as in mid-face division.
Yeah.
And yeah.
But the question is it? So if you look at her facial development, she's got cheekbones.
Okay.
Yeah. So, she's got cheekbones.
Okay. Well, that's good then.
Yeah. So part of it is looking at the Ceph, but part of it is also looking at the face and determining, if her face was flat or angling back. But she's both her jaws are full, right? But they line up ahead of the forehead, which is nice. It's not one above the other. Her mandible is further forward than her maxilla. But how much of that is because she can't bite together, or she doesn't bite together?
Okay.
So there's not quite the information you need to make all the decisions, but you can estimate it, right? So she's when she closes together, she's got a straight profile. It's just a head. And when she bites in her mouth, you can see that it's edge to edge. But her molars, C, D, E, are in class 1. Class 1. Canines are in class 1. That's a slight class 3. But look,
Yes.
is that a true class 3? Or is that an interference and a slide? So you've got to, you need to know exactly where you are before you can make the decision about whether you're going to use skeletal management, such as protraction and auto-rotation closures.
With the smile being a little bit gummy, would that affect the course or management of this child?
Well, is this excess vertical, or is this altered eruption?
I would say because the upper lip looks quite thin and there's a lot of gum above the B's, it could be the maxilla growing down vertically.
Absolutely, and it is. The question is, what can you do about it? And at this point in, in your training, do you have the capacity to change the maxillary vertical?
No, not at this age.
Okay, and then if you use forward pull, what does that do to the maxilla?
That would make it worse.
Yeah, so it pulls it down and forward. So the question is, can you? Is that the goal? And I would say no.
No.
And then how much of this is, you can smile in such a way that you can almost see the frenum, right? So how much of that is what she's doing here? And then let's say we assume that at some point those incisors will touch in let's say a 1 mil overjet. How long is the incisor? Is it that length? Is that fully erupted?
No, not yet.
So there's, that much tooth underneath.
Okay, yeah.
Yeah? Yeah. So all of a sudden, it just kind of depends. So
yeah.
So those are the things that you have to think about. How much coverage is that gum on the crown? Okay. And it's covering more than half of the crown. So when you get the bite jumped over, and then you've got a tooth, will it be the correct position? Especially if she stops, curling her top lip completely under itself. So I'd say that I would focus on correcting the pseudo crossbite first, or the crossbite first.
And that will be with the stage 1 and cat wires.
Yeah. And then you'll have a better idea of where you actually stand as far as the development of the skeletal base. But I would definitely try and get an image.
Yes.
That reflects the correct positioning. Although, I mean, the reality is you probably don't need it, but it's something that you've got to get out of the habit of accepting.
Yes, okay.
All right, so I think that was...
and sorry, one last question. With the lower expansion, would you start that after the bite is jumped over?
Yes.
Okay. Yeah. Thank you.
All right, so I think that is it. We started a bit late and we finished about where we should.
This is a last question, okay, from Rue, who reached work and had just remembered a question. She said, regarding the first case study, shave there. You mentioned you would expand. So regarding the first case study for Rue, you mentioned you would expand the upper and use a sagittal appliance on the lower. Would you start both appliances simultaneously, Also, would the sagittal appliance help with uprighting the nasally tip sixes?
Is that the one with the My Race one?
She's not here, but the first case study, which I can bring up.
Whose was it? Say that again. Ruse.
Ruse, first case one. This is, that was the first link. It's the 7-year.
Yeah, look, I would do it simultaneously, but I wouldn't do it now because she's blown the lower incisors out, and I want the lower incisors to come back to where they should be. So if she hadn't treated the patient before, I would do the lower sagittal at the same time as the upper expansion. But because she's already started to treat the patient, if we're changing treatment course, then I would just allow the lowers to relapse, and I would just treat the upper first.
This is the one, I think. It was the first case study.
Yes, yeah.
That's maybe.
All right. So hopefully that answers the question when you're listening to this. Otherwise, send it over. All right, I think that's about it. Any final questions? We've kind of gone a little bit over. I think most of you, thank you for submitting your very detailed case studies at over half a dozen this time. So really a good session, I think. Hopefully everyone got their questions answered. So this kind of wraps up phase one. So thank you everyone for staying the course. And we're going to be launching phase two. I think, is that a question? Let me see if the question came in or not. We're going to be launching thank you so much. Okay, great. Thanks, Judith. So this wraps up phase one. Phase two is starting in 2 weeks' time. We will. Any questions regarding? I think most of you signed up for phase two, so that's terrific. A lot of you are just doing the recordings, which is fine, and but I hope those of you guys will be doing virtual. So if you've signed up for the live stream, it will be on the 28th, which will be a Sunday, Melbourne time, Saturday US time, or Sunday Malaysia time. So hopefully that will work out good. Any questions in relation to phase two? So it'll be split over 2 days, 28th of June and then one on the 26th of July. And in between, we'll have a live Q&A. So everyone, whether you've got the recording or the virtual live stream, can attend that. The bonus Q&A in between. Do you guys prefer these 2-hour Q&As on a Sunday, Melbourne time, or a Saturday? Because I can always change that.
I think we should stick with the Q&As on Saturday. And then, because the teaching sessions are on Sunday.
Okay, well. Oh, they're 2 weeks apart, so it's not like there's any overlap. Oh, I see, in the future, kind of. All right, so any questions in relation to, once again, the recordings will be generally available within about a week of the live stream for those of you who sign up for the recordings. So in 2 weeks' time, any questions? If only a couple of you guys here who haven't signed up for that yet. The early bird is ending on Monday, as you can see here, for phase two. So prices will jump just about $300 or something like that. So it's getting more intense. It's 2 days split over a month, about a month apart. Give people time to go through the recordings again and get some questions answered. We're going to also have Roland and there's going to be the ENT surgeon and the Max Fax. Will they be on the July 26th?
Yes.
Or the 28th?
Yeah. So Roland and Perry are going to have a session on the July session.
Okay, perfect.
And then Enrico will have a session in 2 weeks, and he'll talk about lab things and an introduction to lab repairs and communication, that kind of stuff.
All right. So, anyone with questions in relation to phase 2, if you haven't, whether you signed up or not, any questions regarding this next phase? Okay. Any other comments, Simon, about it? Otherwise, we'll wrap up.
No, it's might change the contents very slightly, because one of the things that has happened since we last spoke is that the journal article that Paul Ehrlich, Sandra Kahn, and myself submitted to Bioscience, which is one of the big biological science journals with a very high impact factor in the United States. It's been accepted. So, you know, I might go through some of the material that we submitted, so that it helps to tie in the sleep disorder breathing questions that people have. It helps tie in some of the growth issues and how it links with orthodontics. And you know, normally I refer to other people's articles because, you know, they're peer reviewed, but now I can refer to my article because it's peer reviewed as well.
This is a major journal. I have no idea.
Yes, yeah, it's one of the major science journals that helps determine medical policies in America.
So this will impact what in terms of your teachings? It gives more...
It's basically, you know, it's just getting the word out to the medical community of what we're doing.
And it basically peer-reviewed some research saying what exactly for lay people, that so and so.
Oh no, it's just you know, it's just to help people understand that malocclusion, sleep disorder breathing are intertwined with evolution, growth and development, and are not genetically related. You're not born with sleep disorder breathing. You're not born with the malocclusion about to spring out on you. It's all environmentally driven, and there are evolutionary reasons why we are predisposed to malocclusion and predisposed to sleep disorder breathing, and then what we can do about it.
I mean, this is not still generally known amongst lay people like us. I mean, how do we get the word out there, I guess?
We get the word out by having the science and medical community recognize, and then we start to do what I'm doing. Right? We get the medical community to recognize the etiology of malocclusion and sleep disorder breathing is not genetically determined. Then we do research like what I've done with my orthotropy cases and confirm that it is possible to change the course of someone's skeletal growth. And then from there, we become recognized as having valid science. And then we entice universities to start doing some research. And we're also looking at doing that as well with Perry and myself and ENT teams in Spain and Mexico, with Sandra overviewing it. We're looking at running some trials to see if the expansion and the exercise program that I created has an impact on nasal patency and airflow.
Yes, so I mean, you know, this is part of, I guess, why I'm trying to learn as much as I can, because I'm obviously going to be trying to help Simon get the word out there and take GoPEX and other aspects of what you guys are doing, you know, to the general public, you know, creating courses online, and that is scalable, so we can reach a lot of people and get you kind of PR into to media. I mean, media is pretty dumbed down, as we know, and we want simple stories and simple things to grasp that a 10th grader could understand. So our job as marketers is to really dumb down the really complex stuff that you guys are doing with all this.
We need, we can only we want to dumb down real science. We don't want to dumb down opinion. And so at the moment, a lot of this is just opinion, but, as we publish and is peer reviewed, then it's accepted as science. So this journal of bioscience is the American Institute of Biological Sciences. So it's a significant journal and one that we're very excited to be published in.
But is this something that the orthodontic community is kind of resisting, this type of latest research or blah, 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 or are they kind of like accepting it, that maybe there is something to orthotropics or whatever?
No, there's no evidence to show that orthotropics works, which is why we're also doing my case studies.
Hmm.
So until we are able to prove it, it's just an opinion.
Well,
so that's why we're not marketing it. We're not advertising it. We just have to follow the scientific process. We have to follow the system.
Hmm.
And so that takes time. So that's why we teach postural orthodontics, because that's evidence-based, but we don't teach orthotropics because it's not evidence-based.
Okay, so just waiting until there's more.
Yeah, we wait until it is evidence-based and we start to teach it.
Oh, okay. All right, terrific. Anyway, interesting situation. But any other questions? Otherwise, we'll just wrap up. This is just kind of chit-chat time. Feel free to unmute if you want to. See, a dozen of you guys are still here. Whether you've already gone off to do something else on the weekend, or if you're still here, just chit-chat. Otherwise, we'll wrap up. All right, thanks. Good night, Cindy. We'll say our good nights.
Oh, Simon.
Yes.
Yes.
I sent you a picture of my daughter because I just took it today
Cool.
on WhatsApp. So I just wanted to ask if I'm almost there.
Are we there yet?
Sorry, I haven't looked at it.
What's on WhatsApp? Did you send it, Kathy, on WhatsApp?
Yeah, I sent it on WhatsApp because she was before, when she was 4, she was underbite, and then I did forward pull with the mask and it's improved. But then now I'm trying to go for what you suggested. So she's like close to 38 intermolar width, 35 indicator line. But I was getting kind of confused in terms of like Asian noses. Like, I don't know if I should.
I wouldn't look, if it looks okay, then that's good. So I wouldn't I wouldn't get lost in the details of the millimeter here, a millimeter there. If you like how it looks, then it's pretty good. If it looks like it's going to work, then it's close enough. The better you are at something, the more you can fine tune it to make it nice.
Mm-hmm.
The more of a beginner you are, the close enough is good enough. And you've got to determine, if you do more, what does that mean? How much is more? How long will it take? Who's going to pay for it? Who's going to monitor it? What will you get for the energy and effort you put into it? So those are the things that you've always got to determine. Obviously, if it's your own daughter, then you're going to try harder. But will you mess things up from where you are now? So those are the things that working towards numbers is not as important as working to how it all looks at the end of the day.
Okay.
So if you like how it looks, then it's good.
Can you look and see on your WhatsApp if I'm almost there?
I'm looking at it
Or
now.
I need.
Yeah, the teeth have lined up, but I don't see an image of the profile.
Okay, let me see if I can pull that one up too.
So do you want to share it on your screen?
Okay, but it's on my phone.
Okay, so we want to, like, if anything that we do, we want, it's fair to involve the group.
Right.
So if you can get it up on the screen, we'll talk about it.
Okay, I have to. Let's see. Okay, so I have to show you on the video because I can't do it this way.
Unless you send it to Simon's WhatsApp and he can share his screen, then you can open up the.
Okay. Well, I didn't cover her eyes and stuff, so that's the only problem. I did it today. I was just okay. Well, I think her profile's fine. I think her profile's pretty good, but
yeah, if you don't mind showing the photo to everyone, and
okay, I don't mind to. Let me just figure out.
See, I can't share your daughter's image, but you can.
Right. Yeah,
it's your daughter. Yeah.
I know, but I just didn't want it recorded. That's all.
Yeah.
Okay.
I never asked her, and I didn't like cover her eye or anything. So I'm like,
I can stop the recording now, and this won't be on. So let me just stop the recording. Wrap up here.
okay.
So, let me stop the recording. See you guys in phase 2. Stop.